important to us. Number one, the new update in NIH guidelines for the indication for metabolic and bariatric surgery. The second was of course, the major experience, which was during the COVID-19. And of course, the third one, there was a lot of discussion about the pharmacotherapy for obesity as comprehensive rather than as isolated. So all that will be highlighted and will be more by our great speaker with the expert moderator, Dr. Abdullah Zahrani, Senior Bariatric Consultant and Head of Department of Upper GI and Bariatric Surgery in Prince Sultan Military Medical City. As you know, he is double boarded in surgery, AFRCS, fellowship in GI and bariatric, a lot of fellowships and activity in practice and teaching, examination, scientific contribution. Dr. Abdullah is really one of pioneers in the kingdom. Again, Dr. Talal Khwaiter, as you know, he is one of our experts in bariatric surgery, and he is the head of bariatric surgery in Tabuk Military Hospital, King Salman Military Hospital, and head of telehealth department and operating department. Dr. Talal, he is the Saudi Board in Surgery, fellowship on bariatric, member of many society, and he is in addition a surgeon of excellency since 2014. I hope this meeting will enjoy everybody, and please, Dr. Abdullah, the moderator, and Dr. Talal, please, the mic to you, please.
Dr. Talal, if you allow me. Good evening, ladies and gentlemen, and without any further adds to Dr. Sharafa, thank you very much for the introduction, and I'm really too little in comparison to the achievements you have all got. I'm really very privileged and honored to be with you today, and I'm in particular honored to present Dr. Numairi, who is Associate Professor and Chief of Bariatric Surgery at Karanai's Medical Center, Health Director at Autonomy Health Weight Management. He has been with us in the Middle East for some time, and I'm sure you all know Dr. Numairi for his great presentations and contribution in obesity and bariatric surgery. Dr. Numairi, the mic is yours. You will have 10 minutes for presentation, and we'll give 5 minutes for interaction with the attendee. Please.
Sure, great. Thank you for the invitation. Can you hear me?
Yeah.
Great. Thank you, Professor Zahrani, Professor Haider al-Sharafa, Dr. Talal Khwaiter, and Dr. Adel Qahtani for the kind invitation. It's great to see you, Sultan Abu Ali, and Safwan Taha. So I've shared my screen. Can you see my presentation?
No, I don't see. Do you see it?
How about now?
Yeah, now, yes. Now we are okay.
Now you're okay.
Perfect. Okay, great, perfect. So let me just switch. Okay, like that, perfect. So I'm going to talk to you about the top 10 papers that I thought were worth it at the IFSO Miami meeting. The first paper is a paper looking at incidence of reflux and Barrett's after sleeve gastrectomy. It's a 10-year randomized trial. This is the sleeve pass test from Finland. So this was done between 2008, 2010, 240 patients. The primary outcome was weight loss at 10 years, and secondary outcome was reflux, Barrett's esophagus, and remission of medical problems. So 84.6% completed the follow-up long-term, and 77% of patients underwent an upper endoscopy. The excess weight loss was 43.5% after sleeve, and it was a little better after bypass. However, in the design of the trial, you had to increase the weight loss difference by 9% to be significant. So even though gastric bypass had more weight loss, this was not considered meeting the primary outcome. Complete remission of diabetes was had a trend better in bypass, but similar. Hypertension remission also was better in bypass, statistically significant. Rate of esophagitis was 30% in sleeve, 7% in bypass, no different in Barrett's, 5%, 3.5%. The reoperation rate was 15.7% in sleeve and 18.5% in bypass. Their conclusion was that Roux-en-Y gastric bypass had better weight loss, but because of the predefined margin of 9%, that was not considered meeting the primary outcome. There was higher incidence of reflux, and the hypertension remission was better in bypass. So this is the first study. The second study that I thought was interesting was a meta-analysis of more than 1,400 articles, and they, based on inclusion criteria, looked at 16 matched studies and 1 randomized trial. They wanted to look at the mortality after bariatric surgery. So more than 7,700 patients had mortality from 1.2 million patient years. And they found that metabolic and bariatric surgery was associated with reduction of the rate of death. The hazard ratio was 0.49 or 49%. The median life expectancy was 6 years longer if someone had bariatric surgery, and diabetic patients had more improvement than non-diabetics. And obese patients who had metabolic and bariatric surgery had lower rates of all-cause mortality, and it was more pronounced in the diabetic patients. So this was the second study. In the second study also, they looked at the median life expectancy, and it was 9.3 years longer for severely obese patients with diabetes and 5 years for non-diabetics. And the numbers needed to treat to prevent one additional death was 8 patients. And there was no difference in the treatment between gastric bypass, gastric banding, or sleeve gastrectomy. The third article that I thought was very interesting was an article that was from a hospital in Boston, where they made a multidisciplinary center for weight management. And what they did is they looked at the effect of that on clinic volume, both for new patients and overall patients. And they found that their clinic volume for all specialties increased by more than 100% 2 years after they established this center. And the most improvement and growth happened in obesity medicine, followed by endoscopic obesity, 51%, followed by surgery. But the highest number of procedure increase happened in the surgical specialty, 42% growth. So the article highlights that if you make an MDT, you will end up with more access to patients. The next article is a matched analysis from Canada. They matched patients who had surgery to patients who did not have surgery in 20 clinical variables. And they wanted to look at the incidence of major adverse cardiovascular events, or MACE, mortality, including MI and CVA. More than 2,600 patients, 1,300 had surgery, 1,300 were matched controls with a follow-up of about 5 years. The incidence of major adverse cardiovascular events was lower in the surgery group, 11% compared to 19%, and the mortality was 4% in the surgery group compared to 8% in the control group. And especially for patients with congestive heart failure, the rates of major adverse cardiovascular events were 17% in the surgery group and almost double in the control. And if a patient had bariatric surgery, the rate of major adverse cardiovascular events was reduced by about 38%. Then they did a similar study in diabetics, exactly the same study, and they matched patients from Canada using 20 variables in diabetics, 6,000 patients, and found very similar results at 5 years, that the rate of major adverse cardiovascular events was lower in patients who had surgery who were diabetic. The mortality was 2.2% versus 7%. And across all durations of diabetes, the effect of surgery was consistent with a 74% reduction in mortality in diabetic patients. And in this study, they found that both males and females benefited, and the numbers needed to treat was 11 and 14 patients to save 1 life. And the cardiovascular mortality decreased by 75%, again, highlighting in both diabetics and non-diabetics that whenever someone undergoes bariatric surgery, the risk of mortality is actually improved. The next study is the MERIT trial. This is the ESG trial. I'm sure Professor Adel Qahtani is very familiar with this. This is a trial that was done at 9 centers, randomized controlled trial, BMI 30 to 40, and had 5 gastroenterology departments and 4 bariatric surgery departments, randomized a little over 200 patients to ESG versus lifestyle modifications. And the excess weight loss at 1 year in the ESG group was 49% compared to 4%, and was statistically significant. And the mean total weight loss was 16% at 1 year, showing that really endoscopic sleeve gastroplasty is something that we have to watch for, and it's going to come in the horizon. It is still not FDA approved in the US. The next study from the Swedish Obesity Subject Study Registry. They compared the outcomes of sleeve and bypass to look at the incidence of weight regain and the potential for revision. They looked at 44 hospitals in Sweden, enabling the different criteria of no improvement, either excess weight loss less than 50%, weight regain more than 10 kilograms, IFSO ADA criteria 2 years after surgery. And they found in 60,000 patients that the rate of weight regain was higher in sleeve gastrectomy, 23% versus 8% using the criteria of less than 50%. If you use 10 kilogram, 4% versus 2%, using the IFSO criteria, 8% in sleeve, 4.5 in bypass, using the ADA criteria, 3% versus 1.8. And they found that in all criteria in Sweden, sleeve gastrectomy is associated with a higher rate of primary and secondary non-response compared to Roux-en-Y gastric bypass. The next study is a long-term study looking at Barrett's esophagus in patients who had a randomized controlled trial. 109 patients were randomized to sleeve versus bypass. Small numbers, 26 versus 22, but very long follow-up of 6 to 9 years with a mean of 7 years. What's interesting is they found that 8 patients out of 26 of sleeve had either Barrett's or short segment Barrett's compared to 3 in bypass. But this, because of small number, even though it was 30% versus 13, did not reach statistical significance. No difference in long segment Barrett's. Sleeve patients had higher incidence of regurgitation. Sleeve patients had higher incidence of heartburn. And they found that Barrett's and short segment Barrett's tended to be more common in sleeve gastrectomy than Roux-en-Y gastric bypass, while GERD scores and PPIUs showed no difference. Again, showing that symptoms are not enough and PPIUs are not enough to look for reflux and Barrett's. And if you want to look for Barrett's, you need to do endoscopy. And this is why one of the reasons why when we counsel patients, symptoms are not enough. When we look at studies, symptoms are not enough. The final 2 studies are one study 15 years after sleeve gastrectomy, looking at the outcomes in 53 patients with follow-up of at least 15 years, showing that the rate of revision to Roux-en-Y gastric bypass was needed in half of the patients. Excess weight loss at 15 years was 57% in the converted group and 66% in the non-converted group rather, and 66% in the converted group, showing that patients after sleeve gastrectomy has a very high rate of needing revisional surgery 15 years after surgery. And the final study I want to show you is a study from the MBS-EQUIP data set looking at patients who needed revision. So they looked at 15,000 patients and they looked at weight regain is the most common reason for revision. And patients needed a hiatal hernia repair in about a third of patients, whether it is sleeve or bypass. And they found that the most common indication for revisional surgery in the US is inadequate weight loss or weight gain, and that most of these patients will need some form of a hiatal hernia repair. These are the 10 most interesting studies I found, and I look forward to the discussion, and I'll stop sharing my slides. Thank you again for the kind invitation.
Thank you, Professor Nimeri. for these nice catches. And I agree with you. The bariatric surgery is the solution for this devastating systemic disease, and you have clearly shown that. The second I would like to comment on is the sleeve gastrectomy versus bypass. We know that the gastric bypass has better control of gastroesophageal reflux disease than the sleeve gastrectomy. I'd like to give a few minutes for colleagues.
My question here, really surprised a bit. I'm surprised a bit about some results in the neural papers you've shown. That the ROAN-Y is comparable to sleeve in somehow regarding GERD and Barrett's. Is that really logic or just statistical issues or really good, nice finding?
Yeah. So the sleeve had higher Barrett's, but similar PPIUs and reflux symptoms. And this is very well known. Patients with Barrett's disease, the symptoms or PPIUs do not correlate with objective evidence of reflux. And this has been shown many times, meaning the fact that someone is complaining of heartburn or someone is using PPI does not mean they have reflux. You need to do either pH testing if you want to look for objective evidence, or you need to do endoscopy if you look for Barrett's. That's why in the study that looked at patients in the randomized trial, the rate of Barrett's was higher in sleeve gastrectomy, but the PPI use and the rate of reflux symptoms was not higher because many patients after bypass could be using PPI for a marginal ulcer or for other symptoms.
Dr. Talal, are there any other comments? We haven't received any questions yet, but if there are any questions, we are going to discuss it later. And I would ask Dr. Talal kindly to introduce Dr. Safwan to give his presentation, trying to catch up with time.
Thank you, Dr. Abdullah. Thank you, Dr. It's my pleasure and great honor to present the second speaker, Dr. Safwan Taha. He's the director and leader surgeon of the Metabolic and Bariatric Surgery Center at Mid Clinic Airport Road Hospital, United Arab Emirates. He's one of the well-known surgeons in the Middle East, and the mic is yours, Dr. Safwan.
Thank you very much, Doctor. Thanks a lot. It's a great honor and pleasure to be amongst you, dear colleagues, and thanks a lot for Professor Qahtani and the organizers of this webinar for the opportunity to speak tonight. I'm going to share my screen now. Let me see if I'm all right with sharing screens. Choose what to share. I cannot see actually my screen here under share screen. I'm sorry.
I can't see your sharing screen.
Yeah, I mean, I'm pressing share screen, but I cannot see my screen. Let me. I don't know. You cannot see it, right?
No.
Yeah, which is strange because.
Open
I cannot see it
try
here.
again. Sorry, can you try again, Dr. Safwan?
Yeah, okay. You should see it now. I think you should see it now.
Perfect.
Can you see it now?
Yes.
Great.
Yes.
All right. So everybody can see it. Shall I proceed?
Just a second.
Yes, doctor, we see it. Just make it.
Okay, thank you very much.
Yeah,
this is an overview from our hospital. It's a Mediclinic Airport Road Hospital in Abu Dhabi. It's a 250-bed tertiary hospital. I was given the task to talk about the latest updates of the guidelines or indications for metabolic and bariatric surgery 2022. It is a combined statement by the SASMBS and IFSO, which is going to be actually broadcasted on October 21st for the first time. It's still not published. It's not shared apart from IFSO, and they gave us a booklet that contained the combined statement to be published and sold soon. So the major updates to it is that it's a major update on the original 1991 National Institute of Health guidelines for bariatric surgery, and the major updates to it is the following. I'm going to be a bit quick because it's a very long document. Metabolic and bariatric surgery is recommended for BMI more than 35 or equal, regardless of presence, absence, or severity of comorbidities, which is a new thing. We used to have, the guideline was 35 plus comorbidities. The other new thing is that the surgery should be considered for individuals with metabolic disease and BMI of 30 to 34.9, which is class 1 obesity. Again, something new to the arena. And BMI threshold should be adjusted in the Asian population to the point that equal to or more than 25 suggests clinical obesity, and the BMI more than 25.7 should be offered metabolic and bariatric surgery. Long-term results of the surgery consistently demonstrate safety and efficacy, and appropriately selected children and adolescents should be considered for MBS.
اتوقع ان احنا كلنا شايفين الباوربوينت سلايد الاولى فقط.
نعم صحيح كان نفس التعليق.
It's moving here.
Yeah, I think you shared the. Yes.
Yeah. It's now showing. Yes.
If you can stop and share the whole screen, and then.
Yes, I'm actually was sharing the whole screen. So can you see now the other slides?
Safwan, go to full screen. You're not on full screen, like the PowerPoint.
Yeah,
the PowerPoint
now
on presentation.
This is full screen. I'm now full screen. Can you see the new slide?
No. Stop share. Stop sharing and try it again, please.
I'll do that.
Perfect.
I'll do that. I'll stop sharing and then share again. Share screen. What about now?
No. It's coming now, but just what F5 or show the presentation.
Go to slideshow.
Slideshow.
Yeah, I'm
slideshow and slideshow.
Yeah, we have. I'm pressing the slideshow button down. You know.
No. Go to the one on the top. Safwan, go to the top. There is a slideshow bar on the top there. Just press on it.
On the top.
Yeah. Go right, a little bit right. See insert design transaction slideshow. There is a slide.
I've done that also. Just a minute.
No.
Okay. How about you present it like this without the slideshow?
Okay, I think for the sake of time, please go ahead, but just show the slides while you are talking, please.
Let me see. I mean, I'm lost now.
Yes. Now when you click on share screen.
So now it will show now like that.
No, it's not showing anything. Okay, now
I'm
just
really sorry
do F5. Try it last time.
Excuse me.
Or show this. Okay, go ahead, Victor. For the sake of the time, please.
I'm pressing. I'm really sorry. I'm pressing everything, but.
Okay, fine. Just move the slides while you're talking, please.
All right, I'll do that. Just a minute. I'm really sorry for this, but it should work. I don't know what's happening. I lost everything.
Share it back, Victor.
Yeah.
Share it back and carry on, please.
I'm sharing it now again.
When you click share screen, تضغط على الزر بعدين نضغط على الزر على سكرين مو على الباوربوينت.
Yeah. I mean, this is now slideshow. What do you see now? Only the first slide?
PowerPoint itself.
Yes, we can see the first page, the picture.
Only.
Yes.
We can see the PowerPoint, more slide set, more slideshow. We can see the PowerPoint file itself. If you cancel slideshow and just scroll through the file itself, that should be okay. Yes, exactly.
Yeah.
Now we see.
This is okay?
Yeah. Carry on.
That's good. Go with this mode. That will be okay.
Good, fine. Then we'll go for that. All right. So on 1991, the National Institute of Health published the statement on GIT surgery for severe obesity, reflecting expert assessment of medical knowledge available at the time. I'm not going to spend much more time here because you all know that what it addressed, the treatment, the criteria, the efficacy, the need for future research. That's all the old data. The specific recommendation for the practice then were non-surgical programs should be the initial therapy for severe obesity, which is now changing. Selection for surgery to be carefully made after evaluation by an MDT, which is now being more stressed, and lifelong medical surveillance should continue after surgery. And that's still going on. The major difference is that, this is the last statement where BMI over 40, the selection criteria, or 35 with comorbidities as the threshold, and this is changing. Since then, hundreds of studies have been published on the global obesity epidemic, and experience with MBS, metabolic and bariatric surgery, has greatly enhanced the understanding of obesity. It is now recognized as a chronic disease associated with chronic low-grade inflammatory state. I'm actually bringing those paragraphs directly from the statement. I'm just removing the extra fat of the statement and making it concentrated, and that's why it's full of data. So it's now recognized as a chronic disease associated with the chronic low-grade inflammatory state and immune dysfunction that can lead to disruption of hemostatic mechanisms, plus metabolic disorders commonly associated with obesity and involves cytokine production, adipokines, hormones, and acute phase reactants. Other studies with long-term follow-up have consistently demonstrated that MBS produces superior weight loss outcomes compared with non-operative treatment, significantly improves metabolic diseases, reduce overall mortality, and is very safe, with the perioperative mortality ranging between 0.03% to 0.2%, which is why now MBS is very well. It is the most commonly performed operation, or they are the most commonly performed operations in general surgery. How did the surgical procedures evolved? Back in 1991, the NIH consensus statement described VBG, vertical banding gastroplasty, and Roux-en-Y gastric bypass as the dominant procedures in clinical practice at the time. All of you know that currently that sleeve gastrectomy and Roux-en-Y account for around 90% of all operations worldwide, each with a well-studied mid and long-term outcome. Other operations now include still adjustable gastric banding, although it's very much limited in use now, almost extinct. Biliopancreatic diversion with a duodenal switch, one anastomotic gastric bypass. And I added that between brackets SASMBS because it was not in the statement, which was strange because the SASMBS already recognized SASMBS as a primary procedure for obesity, but it was not published in the statement. It will not be part of it. VBG is, I don't think anybody is, I don't know, probably a few people, but it's a historic operation now from the perspective of the SASMBS and the IFSO, and it's not practiced anymore. Of course, by far is doing it the preferred way, which is minimally invasive surgical approaches. And in light of those old data, the IFSO and SASMBS are releasing this statement. The criteria for surgery, body mass index, it is the most feasible. It's not the complete one. It's not the best one, but it's what we have. What are the different? I mean, the differences now is toward the class 1 obesity, which is 30 to 34.9. It's a well-defined disease that, that is recognized now as a problem that needs really to be given the attention for, or the recognition to be there to have bariatric surgery performed. So many studies have recognized that. The International Diabetes Organization published a joint statement supporting the consideration of MBS for patients with BMI less than 35 with diabetes type 2. That was back in 2016. There's a lot of data from controlled randomized trials, meta-analysis, and observational studies that also include subjects with BMI less than 35 consistently demonstrate the weight loss and metabolic benefits of MBS individuals with class 1 obesity. And there are RCTs that are designed specifically to study the population with BMI less than 45 and 35, sorry. And it also demonstrates significant benefits of the surgery in individuals with the class 1 obesity compared with those who don't take the treatment. So this is the most striking difference here, that surgery should be considered for patients with the class 1 obesity. On the other hand, medical weight loss measures have greater durability in individuals with BMI less than 35 than individuals more than 55. So it's recommended that the trial of non-surgical therapy is attempted before considering surgical treatment for class 1 obesity. If attempts at treating obesity or obesity-related comorbidities have not been effective, surgery, of course, should be considered for those patients. And this is the list of the diseases that you all know. I don't want to waste your time with it. Criteria for surgery still with body mass index. Well, I think we talked about that. We talked about that already. This is a repeated slide. All right. So what about BMI more than 35?
Would you conclude, please? Would you conclude?
Oh, conclusion. It's
Yes.
so many things. If I go to
Sake
conclusion,
of time, sorry for that.
Yeah, fine. Then let me go to summary, because there are so many things that we need to talk about. I just want to show you the highlights, the titles, so you can check for them. So beside the body mass index, it's talking about the threshold for Asian population. The extreme of age, older population is now, there is more allowance to do surgery for people more than 70 years of age with BMI, with high BMI. Pediatrics and adolescents, there's more relaxation of the criteria to allow a surgery for adolescents and pediatrics with or without diabetes. Bridge to other treatment, joint arthroplasty, and how bariatric surgery benefits it. Abdominal wall hernia repair, the effects on it. Organ transplantation also, it's a bit complex, but eventually they should be given more. The criteria are more relaxed towards giving them bariatric surgery. And BMI more extreme BMIs, not extreme age. Again, the same thing. BMI 60, more than 60, the results are relatively safe, and operation is safe, and results are great. High-risk patients and cirrhosis, same thing. They are all talking about studies where MBS should be allowed, given more relaxed indications on those cases. Cirrhosis, heart failure, and the patient evaluation, it has to be MDT, should be more extensive, and this is all about patient evaluation. Outcomes, those are the diseases that are affected. I'm finishing soon. Those are the diseases. The comorbidity improvement, including oncologic outcomes. Those are the cancers that are involved, and how cancer risk is involved and improved. And the development of cancer is less, and the cancer-related mortality is much less. The mortality definitely is very low, and the longevity is high after MBS. Revisional surgery can be the reasons why it's done.
I'm sorry, Dr. Safwan, it seems to be very heavy lecture and very nice summary, but unfortunately the time is very limited. I'm sorry to stop you. Thank you very much for your presentation.
Thank you very much. But this is the last hands-on course that we had in London with the guys. I hope to meet you all soon. So thank you very much for the opportunity. I'm sorry, it's a 26-page document, and it's all filled with data.
The time is 10 minutes only. I'm sorry for that.
Not at all. I understand that. Thank you very much.
Okay. I think the discussion will be at the end of the session. So it's all yours, Dr. Abdullah. Please.
Thank you, Dr. Safwan. and you have shed the light on the history, evolution of bariatric surgery. And we all agree with you with what you have presented. As a matter of fact, obesity is a precursor of many diseases. Obesity is mother of many diseases. And unless you attack the precursor, you don't expect to ameliorate these diseases. And clearly, over time, bariatric surgery has shown to be very effective in resolving thousands of obesity-related systemic diseases. When it comes to cancer, I do agree with you, and that has been clearly stated, as obesity creates a state of chronic inflammation, and we all know whenever we relate it to the state of chronic inflammation, what could happen and the chance of malignancy. Without further discussion, though, what you have presented is really great. We will go to our next speaker, Dr. Hussam Adi, and he is a consultant bariatric surgeon in King Salman Al Ports Hospital in Tabuk, and he's going to speak and share with us his view on management of ventral hernia in morbid obese patients. Dr. Hussam, you have 10 minutes for your presentation, please.
Thank you very much. I'll just start sharing. Can you see my presentation?
Yes. If you can go to presentation.
Slideshow. Okay now?
Slideshow. Yeah.
Is it okay now?
Yeah, that's much better. Thanks a lot.
Yes,
Okay,
clear.
thank you.
Clear. Go ahead.
Okay, just I'm going through quickly about how we discussed in the last IFSO meeting in Miami about management of ventral hernia. No disclosure. Actually, it was a whole day discussion about the management, and it was postgraduate course, about 7 hours of discussion. I tried to summarize what have been discussed actually. As you know, the 8% of patients presenting for bariatric surgery has already ventral hernia, and 60% of patients undergoing ventral hernia in the United States had body mass index more than 30. The studies showing that patient with higher body mass index actually and presenting for ventral hernia has higher morbidity regarding wound infection and respiratory also morbidities. What also shown that the recurrence rate is also more than triple of the usual body mass index less than 40. However, in this study did not show difference in the complication rate. If we start by assessment, the advice actually that all patient, morbid obese patient presenting with ventral hernia should be assessed actually by CT scan or dynamic ultrasound. Clinical examination is not enough to assess the size of defects and if what is on one defect or more. And it's actually strong recommendation to do CT abdomen or dynamic ultrasound. One of the important issue that has been discussed actually to reduce the risk of recurrences and complication with management of ventral hernia and morbid obesity. One of the application is the CDAR, Caroline's equation for determining associated risk. It's actually application you can download it in your iPhone, assessing 7 factors: diabetes, tobacco use, previous hernia repair, violation of the GI tract, current infection, concomitant flaps, and body mass index. If you look at this calculation, actually, it's with body mass index less than 30. Once the body mass index jump to 40, you have here a risk of complication 9%. And if you have body mass index of only 40, you see it's now 17%. So diabetes, tobacco use, and use of weight, those risks can be reduced before starting repair patient with ventral hernia. Another important issue, as you know, most of the obese patient has skin folds and they may harbor MRSA. So it's advised to do MRSA screening for those patients, and if it's possible to start a treatment, osmobricine, omitment PID for 5 days, and daily chlorhexidine also for 5 days, and pre-op vancomycin. And if the wound culture came positive after surgery to give doxycycline for 3 to 6 months as chronic treatment, and had been shown by this protocol to reduce the MRSA infection by 37%. So what is the best approach in the discussion? Actually, there is no consensus regarding when and how. However, I'm going to discuss the studies being discussed there. Of course, one of the recommendations that to do these patients ventral hernia with obesity as laparoscopically, because it has been shown that it's reducing the wound infection and wound complication, as well as patient with body mass index more than 30 has higher incidence of recurrence as well. So therefore, the grade B recommendation to take care with additional technical steps like more mesh fixation, more overlapping, and to close the defect as well. In one study from Cleveland Clinic, they looked to the patients, so 85 patients actually, and with follow-up that reaching 26 months. And they compare patients who had repaired the ventral hernia during the bypass using biological mesh, and there was no recurrences, and the primary repair was 22%. And those cases which they reduced the hernia without any other repair, and they left the defect open, they presented with bowel obstruction in 36%. So the advice at that time, don't defer the hernia repair if it was reduced, either to leave it or you have to do something for that. The same group showed that concomitant repair of ventral hernia with the bariatric surgery associated with higher incidence of adverse events, as well as 30-day readmission and reoperation rate. However, some studies claim that primary repair has higher recurrence rate, like these studies that have less than 8% of recurrence rate after primary repair during bariatric surgery. If you look to this study, they compared 115 patients who underwent primary repair during bariatric surgery and 44 patients with mesh repair. It's a biased study because when the defect is large, they applied mesh, and it is small, they do primary repair. They did primary repair. And they found that the hernia defect size was the independent factor for recurrence later on. As I said, because these patients, they used the mesh when the defect was large. So also discussion was about what type of mesh to use, especially if you are doing concomitant bariatric surgery and you're opening the bowel. Like this study, they use the IPOM technique, and they use actually composite mesh, and actually there was no recurrences and no infection. In this study, they looked for the 26 patients out of 325 with ventral hernia, and the 18 patients underwent concomitant repair during the bariatric surgery, 8 of them primary and 10 with synthetic mesh, the proceed mesh. There was no infection or recurrence in the stage, while 8 patients underwent late repair. You can see from this one that concomitant repair is actually feasible. However, if you look to those patients with body mass index more than 50, you can see in this study, they looked for 27 patients with ventral hernia. All patients who underwent concomitant repair, whether with mesh or primary repair, all these patients had recurrence of the hernia, while the other patient had late repair and no recurrence. As you know, many studies showing that body mass index 50 associated with 100% of recurrence of ventral hernia if you prepare as primary without reducing weight. One of the algorithms which has been suggested in 2013, looking to the anatomy of the ventral hernia, whether favorable anatomy or unfavorable anatomy, looking at the body habitus or hernia location central or hernia size, less than 8 centimeter, body mass index less than 50, and the body body wall thickness less than 4 centimeter, or reducibility of the hernia. When we have favorable anatomy, they advise to do as concomitant repair. So the algorithm that he suggested, dividing patient to favorable anatomy or unfavorable anatomy. And if you have favorable anatomy with symptomatic hernia, to do the ventral hernia first, then bariatric surgery. If favorable anatomy and asymptomatic, you can go for concomitant ventral hernia and bariatric surgery. And on the other side, if favorable anatomy and patient is symptomatic, it's advisable to go for medically supervised diet with very low calorie, less than 800 kilocalorie. Then you fix the hernia, then later the bariatric surgery. If you have unfavorable anatomy and asymptomatic hernia, it's better to go for bariatric surgery than to repair the hernia after 1 year to 18 months. One of the algorithms also has been suggested, again, looking for the symptoms of the patient. If the hernia is symptomatic, significantly symptomatic, they fix the hernia before the bariatric surgery. If the hernia is symptomatic or mild symptoms, look to the size of the hernia, if it's small or large. Again, here was the discussion about most of surgeons are afraid to use synthetic mesh during bypass, while they may use synthetic mesh with the sleeve if they want to repair the hernia. One of the protocol, which was suggested by Brian Jacob, which is known as a good hernia surgeon, advised to do ventral hernia repair when the body mass index less than 30. If patient doesn't want to do bariatric surgery, he explained the risk of recurrences, and he proceed for IBM with or without defect closure. If patient present with obesity and ventral hernia, they prefer to postpone the repair of the hernia till later stage after 6 to 18 months. However, if the ventral hernia is symptomatic or have bowel containing, again, they can prepare it primarily or using mesh if they're doing the sleeve. The SASMBS recommendations that repairing of ventral hernia during bariatric surgery is safe and visible. However, there is no enough data regarding using synthetic mesh in that setting. On the other side, if the patient presenting with severe obesity and the hernia is not able to for laparoscopic repair at one stage, it's recommended to do staged approach, and then the patient will have weight reduction during surgery or medical management. Then to go for, yes?
You have 1 minute to conclude, please.
I'm going to finish in 1 minute, inshallah. One important issue, actually, the size of the mesh actually should, as I mentioned earlier, the technical steps is very important. The hernias, the mesh should be at least more than a mesh to the defect more than 16. Like if you have defect of 4 centimeters, the mesh should be 16 centimeter diameter. Why not to reduce risk by MBS? As you have many obstacles, especially by insurance, and many patients are not aware or don't want to do bariatric surgery before the ventral hernia. Another important issue was discussed also the presence of the diastasis recti in the presence of hernia, and they divide the patient to obese or non-obese. If the patient obese and they have wide rectus muscle, you go for E-tape. While narrow rectus muscle, you go for TAR, which is questionable for me, or non-obese, you go for indoor, which is called Cicola subcutaneous only repair. And if you have contaminated field, you go for a LERA technique, which is lap intercorporeal rectus abnormality. Finally, actually, recommendation that you need to fix the rectus divertication, otherwise, because it's one of the risk factor for hernia recurrence. We discussed also the presence of groin inguinal hernia and obesity. As you know, the obesity, one of the factors that has less patient with the inguinal hernia. Only 5.2 of inguinal hernia had body mass index more than 30. It's also the surgeon preference to go for laparoscopic or open repair. Also using to repair the hernia during after a bariatric surgery, as the complement was pancreatectomy, there was also conflicting data with higher complication up to 55% if you do both the hernia or with the plastic surgery. And other studies showed there was no statistically significant. However, the quality of life was better if you do combined surgery. Thank you very much.
Thank you, Dr. Hassam, for this nice presentation. And I personally agree with you. Ventral hernia repair with obesity is challenging. Three approaches are known: repairing the hernia before bariatric surgery, and that carries the highest recurrence. Hernia and bariatric surgery, there are a lot of studies have shown the safety of hernia repair during bariatric surgery, whether you do primary or you do mesh. But again, the recurrence is high, as it will take them around 18 months to lose weight. So the hernia may repair at this time. If the contour of the abdomen is not restored, there is a chance of the mesh that will fall inside the sac and may cause skin erosion after losing weight. And the best, as a matter of fact, is the repair of hernia once they have lost their weight and restore physiological intra-abdominal pressure. I'd like to hear from other colleagues, speakers, if they have any point to add on this subject before we move to the next. Anyone would like to?
Abdullah, there is one question from Dr. Osama Faida from the attendees. He said,
we'll come to it. If you could kindly ask, let's ask the speakers, and then we will get to Dr. Osama question.
إذا ممكن I have a small comment, Dr.
Please, Dr. Haider.
شكرا Dr. Adi. I think this extensive discussion and controversies indicate the absence of the consensus. But as you present, the safest way is to have it in a stage way. The best way, what the results show in your studies, is to have it in a stage way. Probably there are individualized feature, as you mentioned, high risk, low risk, bad factor, good factor. But the problem is not in the very high BMI or very low BMI, but probably in the middle, those who are between 35 and 45. In your review on in these studies, those group of patients, what is your feeling about it's the best?
Yeah, thank you very much. Actually, we are having in our center one of these algorithms, actually, which was used by George Eid. I'm looking at those factors. We are doing CT scan for all these patients. We are reluctant to do any ventral hernia with body mass index more than 35. We advise them to lose weight. Either they accepting bariatric surgery, even if they come to us for ventral hernia repair. Many of the patients, they don't have any idea that they are candidate for bariatric surgery, and they go for the pathway for bariatric surgery, and then we do bariatric surgery. If intraoperatively we had to reduce the hernia and it was difficult for us to do the surgery without reduction, we have to reduce the hernia and to go for primary repair. Some of the cases, as we said, we put for them mesh. Actually, we advise for biosynthetic meshes. We are not using synthetic meshes for fear of infection. We have good results so far. And again, any patient more than 40, the recurrence rate is actually jump from 4% to 16%. And in body mass index more than 50, it's up to 100% the recurrence rate of ventral hernia. So this is actually any patient more than 35, we advise them to lose weight, either by bariatric surgery or other methods.
Dr. Hussam, we have a question from one of our colleagues, and he's asking, if you are fearing infection, what mesh would you recommend?
Yeah, as I mentioned, actually we are using biosynthetic meshes like physics or BioA. What we have in our center is the physics mesh for the ventral hernia. So this is what we're using for during the bariatric surgery.
Thank you very much. Dr. Talal, if you could kindly introduce our next speaker.
Okay, thank you. Thank you very much for the speaker and for you, Dr. Abdullah. The next speaker, Professor Dr. Musa Khurshid from Kuwait. He's a professor in Department of Surgery, Kuwait University. He's well known in Kuwait, and he's working in Taiba Hospital in Kuwait. So, Dr. Musa, please, the time is yours. 10 minutes and then 5 minutes for discussion, please. Thank you.
Thank you for the kind invitation. I would like to congratulate you for such a wonderful work. It is my pleasure to come and join you tonight. I'll start with this. I hope you see my shared slide now.
Yes, 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 we can see it. Yes, go ahead.
So this is a big topic actually, and I'm trying my level best to sum it up and put up some of the points that are of importance. Now, this is the course that covered different aspects of bariatric surgery, and there are videos and case scenarios that we cannot discuss at this point. Now, as you see from this 2016 IFSO worldwide survey, that about 7% of revisional bariatric surgery account for the total. And this is the definition, the old definition of revisional bariatric surgery and the outcome of surgery. Do you hear me?
Yeah? Yes, yes.
Very
yes,
well.
Yeah.
Okay.
Yeah, very well.
So how to define success and failure in reoperative bariatric surgery is important. Is it amelioration of comorbidities? Do we need to operate on someone whose BMI is excess body weight loss is less than 25 with amelioration of comorbidity? Do we have another important factor such as the quality of life? The majority of patients define failure of bariatric surgery as less than 50% excess weight loss at 18 months. Now, we all know that there are risks of revision performed for weight loss failure. There is inconsistent weight reduction and serious perioperative complication, risk of leak, urgent reoperation, and however, laparoscopic revision is quite safe. So we said again, 5 to 8% of primary surgery fail. And the main reason is a primary inadequate weight loss, weight regain, and complications. So we need to know that we might be choosing the inappropriate patient, poor patient education, and lack of multidisciplinary approach, which is important. Important issues is we have to look at the anatomical factors, failures, patient compliance and behavioral modification, review of operative notes, anatomy, and you have to know your limitation. You have to be realistic with the patient, expected weight loss, risk of complications, long-term outcomes, and should be undertaken by well-experienced surgeon. How experienced, that is defined in the course too. Make sure you have enough blood, do endoscopy, radiology, get a nutritionist, psychiatrist, and involve the patient in exercise program. Now, we have 3 kinds: conversion procedure that change from an index procedure to a different type of procedure. You might need to correct procedure by doing correction of that procedure or reversal of the anatomy. This was discussed, revision of adjustable gastric band, and you have got different options. I don't need to go through this, but because for the sake of time, the mini gastric bypass, you have to be aware of these complications. Those are the marginal ulcers, what you do for them. The other issue, which is GERD, what do you do for it? You convert it to Roux-en-Y gastric bypass or reverse it. And then the malnutrition, which is a major issue, and that depends on the length of the BP limb. So important issues that I focused on this is the ethical consideration of revisional surgery. And these principles are the autonomy, beneficence, non-malfeasance, and justice, and which are viewed by many as a standard theoretical framework from which to analyze ethical consideration in medicine. Autonomy refers to an individual right to self-determination. It is the foundation for informed consent, and the patient have to have the full intention and understanding of the procedure. Beneficiaries, there is no doubt that the bariatric surgery is efficacious and cost-effective too. Adding the principle of first do no harm. So you have to remember this, that you should not be harming your patient. And that is something I mentioned at the beginning. Now, justice is important. It reflects the need, a fair and equal distribution and allocation of healthcare resources in the society. So we should avoid the stigmatism. And there are three main concepts: the recognition that all resources are finite, and then individuals need to be respected, and morally established and accepted laws need to be upheld. So there is also an important issue, the ethical responsibility on clinician to target treatment at bariatric patients with the greatest potential for improved health. Patients with obesity-related diseases are no doubt the priority. And those observations have important implications for the government policy, for healthcare resources allocation, and for future clinical programs for obesity treatment. Another issue is the disordered eating patterns, cognitive behavior therapy. What are the therapeutic implications for optimal? You know that we have many diseases, including eating habits, the grazing, binge eating, etc. Some of those patients, they have depression and they become alcoholic and attempt suicide. So these are the problems of eating behavior, and the ways to intervene and correct these behaviors like erratic eating, meal skipping, unhealthy food, nibbling, grazing, etc., etc. So weight regain is its behavior of biology. Changes in regulatory gut hormones such as GLP-1, cholecystokinin, and others occur. Patients who start experiencing weight regain often are aware of the changes in their perception of satiety and report recurrence of overeating behavior. The physiological basis behind the regulation of satiety after bariatric surgery remain incompletely understood, and hypothetically, the beneficial effects of gut hormone changes may become blunted or counter-regulated by other pathways over time. Now, what about the role of medication? This is the American Association of Clinical Endocrinologists, and it's becoming the roadmap for many policymakers even, and the government to adopt these guidelines. It's about 130-page document that talks about when to interfere and what to do for those patients. When we look at post-bariatric surgery, the role of medication, we have got almost 5 drugs, and the only one, we all have insufficient data regarding their effect. Data were available for only largactil 3 milligram and showed some benefit. About endoscopic revision, do they work and for how long? We have different types. The sclerotherapy, we do inject the gastrojejunectomy until the diameter is 10. 2 to 3 sessions are required, and endoscopic suturing has been shown to be better than sclerotherapy. Then we have the cryoablation, and you can see the total body weight loss can be up to 8.1%, which was achieved. The APC, you need to have 3 separate sessions every 6 weeks, an optimal outlet size of 1 centimeter. High dose APC has been shown to be better in terms of weight loss at 1 year. Then we have got the full thickness suturing, Toure and Rose. And you can see these are meta-analysis on a few studies, including 850 patients. In 12 months, total weight loss is 8.5. The pooled adverse adverse events were 11%. Another systematic review looking at endoscopy, and you have different endoluminal plication, other techniques, and the combination therapy that has been included in this meta-analysis. Endoluminal plication devices show the greatest initial weight loss within 12 months post-procedure, but not sustained at 11 months. Only one study utilizing sclerotherapy showed a greater sustained weight loss with a peak weight loss at 18 months. Combination therapy showed the greatest sustained excess weight loss at 18 months. Endoluminal plication devices were more successful, performed in 91% of patients, and had lower recurrence rate compared to others. Both procedures demonstrate no major complication and low rate of moderate complication. Only mild complication were included, were seen. And then we come to Roux-en-Y stasis. This is it a real disease or not? So you notice that I focus on things that we probably don't see every day. However, sometimes you need to do revision. Those patients will complain of fullness and distension, abdominal pain, stasis of food and secretion in the atonic or abnormally contracting jejunal limb. It has been proposed due to blockage of electrical conduction caused by cutting of the jejunum. They lose the stimulation of pacemaker, and there is due to disruption in continuity of small bowel. This may cause ectopic pacemaker to arise in the Roux limb, and these pacemakers drive the contraction of the proximal part of the limb in reverse or oral direction. This creates stasis in the Roux limb. 1/3 of our patients, to my surprise, that this occur after Roux-en-Y gastric bypass. And there are people who have shown endoscopic placement of 2 temporary electrodes, 1 on each side of the jejunal limb might help. There is significant in EEG parameters, marked improvement in the GI symptom score and the quality of life. And this is how they do it. Now, another issue, interception, when to intervene and what to do. I would advise people to look at the GG anastomosis, and we have many problems that can occur. This is a Swedish study, and most patients with symptoms of dysfunction
2 minutes, Dr. Musa.
I'll finish soon. Total relief following revisional surgery, but the substantial minority had persistent problems, with 1 in 5 eventually undergoing reversal of the anatomy. Interception is rare. It's the incidence is 0.1 to 0.3%. It's due to thinning of the mesentery. The cause is not clear. However, some research suggests this motility as a cause of interception post-gastric bypass. Usually it's retrograde. The onset is acute abdominal pain. You do a CT scan or MRI that shows a pseudokidney. Either you reduce it or resect it. So this is one of the case reports. Usually most of the cases are case reports in the literature. So thank you very much for giving me the chance to present today. Thank you.
Thank you very much, Dr. Musa. I really congratulate you for this perfect and nice review. It's very clear and straightforward. I have just a question for you, if you allow me. What about the smoking and tobacco use Any recent recommendation or any clear guidelines?
Well, of course, everybody, you should abstain from smoking and alcohol prior to surgery. If you look at North America practice, you have to go through, a system of, they take examination, history examination, and so on. And then you have to go through a course that you have to pass. And you have to prove that you abstain from tobacco and alcohol prior to any bariatric procedure.
I believe this is really maybe not applicable in our community, majority of our patients are governmental or, supported by companies. So this is really not practical, I think, in our community. Any other? Yes. Dr. Sultan, please. Go ahead.
Thank you very much, Professor Khurshid. I enjoyed the talk, and I totally agree with you and that we have to be honest with our patient and fair with them. Revisional bariatric surgery, our patient, they come, they ask for outcome. They want to improve the results of the previous 1 or 2 or even 3 surgery. But we should remember that our job as a surgeon or clinician to provide a good anatomical and physiological procedure. Our job, we should do safe procedure, not only the outcome. There are so many issues now in bariatric revisional surgery. We worry a lot about reflux disease following bariatric surgery, GERD, marginal ulcers, and malnutrition. So especially in malabsorptive procedure or let's say GI procedure, gastric bypass or anastomosis gastric bypass, for revisional procedure, we are going very aggressive, looking for just the outcome, weight loss. We have to be careful about the long-term consequences of this procedure. We know that the outcome in terms of weight loss is disappointing for us and for our patient, especially after 10 or 15 years. But we can do very good thing in minimizing these complications, especially in one anastomosis gastric bypass, especially in smoker patient. We have lots of marginal ulcer, high rate of marginal ulcer in smokers. So smoking, marginal ulcer, malnutrition, GERD, these are very important issues that we should take into consideration. Thank you.
I cannot disagree with you, Dr. Sultan. I'm sure that a person like yourself with a huge experience in this field, I know you for the past more than 20 years doing all those procedures. And revisional surgery is a huge subject. We can take only one topic and we would stay hours and hours talking about. However, I tried in this talk to give a message, and I think that is the point behind it. In 10 minutes, you cannot cover the whole subject, and so forgive me if I didn't cover all the things, but I was trying to give a message.
Agree. Dr. Abdullah, please. Unmute, Dr. Abdullah. We can't hear you.
Yeah, Professor Musa, thank you very much for this nice presentation, and it's an honor to have you with us. I cannot agree anymore, to be honest with you, and I would rather quote what you have said, just do no harm. I think we, as a bariatric surgeon, we should believe in, there are some patients who are non-operable. We should take that into consideration, and unless we push them to comply with the requirement of the surgery, it might not be safe to operate on them. And here I would like to pay attention and recommend all to the patient education. There are many patients coming to surgery and thinking that it is a procedure that I'm going to do and I'm going to get rid of obesity forever, regardless of the risk, regardless of the the change of the lifestyle, and we have to pay attention to that. Thank you very much.
Thank you.
Thank you for your comment, Dr. Abdullah. Any other comments from the panel, please? I think also we did not receive any questions from the attendees. Dr. Haider, yes, please.
Assalamu alaikum, Prof. Nice to have you with us in this nice webinar. I think revision is individualized, not only for the patient, as from presentation looks like, also from the surgeon point of view or from the facility itself. So you can revise the bypass by doing endoscopy or by laparoscopy or by taking a medication or by adding length. I think these extensive revision tools make the revision more and more controversial and rather standardized. But probably the question, which I hope that will be the more important for me, yani, a patient who is fit for surgery, but we should not do revise him. Can you get some, I mean, do you have any idea of those patients who is fit for surgery, but we should not revise them?
Yeah, I fully agree. There's no doubt there are many issues. I will give you an example of a lady that I have operated today. I did for her a bypass about in the mid-2000s. Then she has seen someone else who has done laparoscopic pouch resizing. And then she came back, she lost the weight, and then she came back again. So we sent her for behavioral therapy, we sent her for nutritionists and so on. In our culture, sometimes there are people who would believe that you can do magic for them. Now, this is a lady who had also a laparotomy. She had lots of adhesions. We couldn't get in today in the laparoscope. So you have to accept sometimes your inability to perform those procedures. We wanted to do a distalization. Now, another issue in our culture, which is the dietary habits in our culture. Many people, they like carbs, they are sweet eaters and so on. So if you do a distalization, I mean, we've seen the history from 50 centimeter of common limb to 100 centimeter to now people are doing it as 300 centimeter. Why do they do this? Because of malnutrition, long-term malnutrition. So those patients, if you want to do a malabsorptive procedure in the future, you have to be careful that they are taking the vitamins. You have to follow them up. You have to call them. You have to contact them because they can end up with liver failure. They can end up with disaster. So I think this is an issue that we have to remember, especially in our culture in the Middle East. I don't do the Saudis, and because the Saudis, I know most of our patients, if I would do a distalization. So I think you can face disasters with revisional surgery. So risk of complications are higher, you know, ICU admission is higher, leak is higher. So remember these things before you decide to do what to do for the patient.
Okay, thank you very much for the nice discussion. I think for the time sake, we can proceed to the next speaker. Dr. Abdullah, it's all yours. Thank you.
Thank you all. And last but not least is my friend, Dr. Sultan Al-Timyat. He's a consultant, minimal invasive and bariatric surgeon at Badana Clinic, Dammam, Saudi Arabia, and he's well known to you. To me, he is a poet in bariatric surgery, and today he's going to present us a speech on what you should know to publish your paper. Dr. Sultan, you have 10 minutes and we are honored to have you, please.
This is the last talk. Maybe you can give me 1 or 2 minutes more.
But 11 o'clock finishes at 11.
You know, this is First of all, good evening, everybody. It's my honor and my pleasure. Do you see my presentation?
Not yet. No. Share screen. Are you sharing screen?
Just a second.
Yeah.
I'm sharing the screen, but it's not coming. I have to open my presentation first.
Yeah. Put it in the desktop and then you can share it, I believe.
Sorry for that.
That's okay.
It's not coming. Why?
Maybe if you close it and open it again.
Okay.
We don't see anything, Dr. Sultan.
Just a second now.
Yeah.
The problem, my desktop is not showing here.
If you open it in the desktop and you'll see it in the taskbar down there, you can press and push.
The problem, it's Apple. This time I use Apple.
Well, why did you use it tonight? Why didn't you use it some time ago?
I'll try to close and start again.
Please do. Dr. Talal, do you have any experience with Apple?
No, actually, no. I'm using Windows since a long time. The
Now
only
I'm
phone.
opening the talk in the desktop.
You may need to restart, Dr. Sultan, everything, even the Zoom. The Zoom contact.
The Zoom is okay now.
محمود يساعدنا في عملية الإرشاد.
They can.
Yeah, do you see the green share screen button? Do you see the green share screen button? Is it visible?
Yeah, I'm pressing that, but it's not coming.
Wait, you can share the whole. There's security. Yeah, there's some. Yeah, I think you may have to change the security features on the Mac for you to be able to share the screen. It should tell you. It should give you like a pop-up message. You have to change the security settings first.
So, Dr. Sultan, what about sending it to Sarah email? She will open it and then we can go through it.
Or you can send it to me in chat here, directly through chat, and I'll open it and I'll share the screen. How does that sound?
Let me try to do something. I will just give me 1 minute. I will put everything off.
No, I will call you Dr. Sultan.
Call me, yes, please.
So, Dr. Abdullah, just to buy some time, you can just go for discussion. There are some questions here, if you see in the chat, for the previous speakers.
Yeah, there were some questions which I tried to answer most of them.
Yeah. About Barrett's esophagitis incidence with gastric bypass still happen, and still do we advise to convert sleeve to gastric bypass, and still the risk of Barrett's is still high? This is really, I think, an interesting question, if there is any experience with the panelist. So Nimer is still with us, or he left? Abdul Rahman? Any experience from the panelist, please?
You know, Dr. Talal, the Barrett's esophagus is known as
Can you hear me?
of the reflux esophagitis, and it is known in normal population. So do you expect it after sleeve gastrectomy? Yes, because the incidence of gastroesophageal reflux disease is higher. There is again some incidence of gastroesophageal reflux disease in gastric bypass because of other etiologies, either unrepaired hiatal hernia, narrow gastrojejunostomy, bigger gastric pouch. So they are still liable to have gastroesophageal reflux disease and Barrett esophagus. But if you compare the two, the gastric bypass has less incidence of gastroesophageal reflux disease and Barrett esophagus. And even if
Dr. Abdullah, can you hear me?
Bypass, you have to look into the cause and then you treat accordingly.
Yes.
Thank you.
Yes. Dr. Abdulrahman, we can hear you, yes. But the question here is, we consider bypass is the revisional surgery for sleeve as a complication of reflux and GERD and Barrett's. Now you are saying the RONY is comparable to sleeve in Barrett's. That's the question.
It is not comparable. I think what's important to note when you revise a sleeve gastrectomy is, just like the MBS equip study that I presented, you need to look for a hiatal hernia, especially on the left side. And just like it was mentioned, if you do a Roux-en-Y gastric bypass and you leave a large pouch, there is incidence of reflux on the large pouch. So the study that I presented did not show that Barrett's was the same between sleeve and bypass. To the contrary, it showed that Barrett's was most common in sleeve, but it showed that the symptoms of reflux and PPI use is similar between both. And the reason is because symptoms don't necessarily always correlate with Barrett's. And I think that currently, if someone has Barrett's esophagus, the only treatment that could lead to regression in Barrett's in 30% of patients is Roux-en-Y gastric bypass. And there's at least 3 small series that show that.
If I may comment, Dr. Abdurrahman, good to hear from you. And you know, someone has to think. I've never thought about the Roux stasis, and you know, that could explain why some people, even after the bypass, they have reflux, they have bloating, they have heartburn, and they have regurgitation, and that could be explained by the Roux stasis, the Roux limb. And I
agree.
You know, it just give me this. You know, I had the chance to review this topic and read about it, and probably that explains why some people still continue to have reflux after the Roux-en-Y gastric bypass, and even they develop Barrett esophagus.
I agree, Abu Khalid, and I think one of the most common reasons to have Roux stasis syndrome is a large pouch. There's a Brazilian study of about 67 patients where they did CT volumetry and scintigraphy about 4 years from surgery. And the pouch empties the most and the fastest when it is less than 40 milliliters in size. So the larger the pouch, the more chance someone could develop Roux stasis syndrome and then have reflux. I agree.
Abu Ali, you are absolutely right, but sometimes we see it even with a smaller pouch. Less than 25 cc, and yet you still have some patients with symptoms.
Yeah, if there's hiatal hernia, I agree. I totally agree. I agree. Yeah.
So just to wrap up this the discussion, what's your advices actually in Roux-en-Y to avoid the risk of GERD? I mean, risk of future Barrett's after conversion to sleeve or from sleeve. So in general, the small pouch and any other advices from the panels?
أنا إذا تسمحوا لي دكتور طلال أعتقد ما أضيف على ما قاله الزملاء وإنما what I believe is that if you revise sleeve for GERDs, please repair the hernia and please make the pouch smaller. And in addition, I have some of probably couple of cases where even after bypass, still they come later with reflux, and we need to repair the hernia, and probably sometime we do rub them as a rub around the pouch. So and so what my thinking in all cases who I revise the sleeve because of GERD or Barrett's or severe symptomatic reflux, in all of these cases we do look for the hiatus, and we do repair the hiatus and reduce, of course, the sleeved stomach intra-abdominally. And sometime, of course, if we do revise for the raw NY, we use the excluded fundus in order to use it as a wrap.
Thank you very much, Dr. Haider. Dr. Sultan, are you okay? Can you open your mic, please? Dr. Sultan, your mic. Yeah. Are you okay?
No, still not yet. ممكن اسوي البرزنتيشن، انا اقدر اشوف السلايدز حقتي تقدروا تسمعون صوتي.
Yeah, that will be okay.
بعض الاشياء اللي
Yeah, please. Maybe you can send it to Sarah and she can go along your speech. Did you try to email it to her?
No, I think it's difficult now. Let me just talk, Abdullah, for the sake of time.
Yeah, please.
You know, it was difficult presentation for me. Now I made it even more difficult.
No. You don't blame me for that. We are pleased to have you.
Abdullah, the picture is not clear for Dr. Sultan also. It's not showing like reflection or something.
Yeah, I can see his mustache, so that's okay.
Pictures, no, pictures I can't even, okay, no pictures now, just sound, okay?
Okay, well, yeah.
Okay, sorry for that.
No problem. Okay, you will start the time now, huh?
Please.
Okay, in Miami, IFSO, we have attended a pre-Congress workshop about how to write a paper and how to improve your publications. It was almost 8 hours course, and here I'm trying to summarize it in 10 minutes. Unfortunately, I'm not able to show you the slides here. You know, it's not my presentation. What I'm trying to do to give you some highlights from that meeting, and I just want to refresh your knowledge about how to write a scientific paper step by step, and we try to cover the important things. Usually, they like when you decided to write a paper to start by literature review. You should review the literature first to understand what's already known, and also to identify the knowledge gaps in the research topic you want to discuss. If you want to talk about reflux or GERD following sleeve gastrectomy, you want to review the literature about that topics. You see what's being published, what's the knowledge gaps, and what you gonna add to this topic. The roadmap usually of any paper consists of questions of the study design, the population, the measurement, and also the analysis, and at the end, the interpretations. It's very important to discuss the questions of the study, what's already known, what are the knowledge, we said the gaps, and how other approach the research questions before. It's very important to know that whether your research is visible, interesting, novel, ethical, and relevant, and also the framework and the roadmap of the research itself. You can imagine with me the slide that I'm presenting. that you should know the type of the research, who and what to study, when and how will data be collected, how will data be analyzed, and how will data be interpreted. We have the research study design, we have the descriptive and the analytical design. We have the case report, case series, cross-sectional studies, case control study, cohort study, etc. And the cross-sectional studies, we have to know in ahead of time the strength and weakness of each study. The strength for cross-sectional study, it's simple, it's inexpensive, limited challenges, and the cross-sectional study could be the first step of cohort study. The weakness usually primarily suited to describe the prevalence, not suited to determine the causality, and the risk of bias is usually high. Case control study, also we have a strength point and weakness. Then we have the essential of research success. It's a well-defined hypothesis. The study design is important. IRP approval, funding, data collection, analysis, and manuscript and publication in a high-impact journal. The goal of each section of the article is important. Abstract, introduction, methods, results, discussion, conclusion, and reference. It's very important to discuss each section. The abstract, the title and abstract is very important. The article title and the abstract help you to decide whether the article merits closer attention. And you cannot trust the conclusion until you have read the methods and data. It's a question relevant to your knowledge or practice of medicine and not suitable for critical reading the whole article. So the abstract is just to attract the attention of other people to your paper. How to pick the correct analysis? It's very advisable to start. The tip number one, to consult a statistician from the beginning. It sometimes is our big mistake just to inform them at the end of our work. No, you should let them know about your study in the beginning, and maybe later on you inform them at the end of the study. Use the internet to search the correct analysis. Use a statistical package. There are so many software now in the internet that you can utilize. The figures is very important to use. I have here illustration. Unfortunately, I cannot show you that you can recruit them in your study. It's photo, sketches, drawing, graphs, diagram, flow charts, and maps. These are very important that you should know the details of these. We call them all figures. The guideline for figures: ensure image clarity, use legend to explain the key message, and label all important parts. I have here diagram shown to show you the badly designed graph and the better graph design. Unfortunately, I cannot show you. And how to write, now the questions, how to write a winning scientific manuscript. There are three broad groups for manuscript: original scientific articles, review, and meta-analysis and case reports. How to write a winning scientific manuscript. Ethical issues are very, very important. We have to be very careful about fabrications of data. Sometimes you give assignment to one of your junior or student, and you ask them to collect data, and for the sake of the time, or they don't know it, they just fabricate the data or just fill it up. Sometimes duplications of the application of publication itself, misuse of statistics, manipulation of image. These are problems of, these are usually ethical issues. How to write? Start with making figures and table. First of all, you do your figures, you do the tables. Then make the summary. Then write the materials and method and results, followed by discussion and reference. At the end, you decide the title and you write the conclusions. The title, it should be clear, brief, and specific. It should reflect the purpose of the study. And the abstract is the last section to be written, but it's most important one, usually the first to be read. Readers use the information contained on it to decide whether to read the whole article or not, just from your abstract. It should be concise and a concise summary of the manuscript. Introduction, important, material, methods. I will just skip that for the sake of the time. To go to what is the journal looking for? Now you finished your paper, you have written your paper, you want to publish it in one of the recognized, credible journal. There are so many things that you should follow. Each journal, they have their guidelines and they have their policy that you should be aware of that. One important thing, they write for in each journal, you found instructions to the authors. You have to read them. Usually they are found in the journal website or inside each issue of the journal. And it's usually unique for each journal and must be followed exactly with the manuscript. Otherwise, the manuscript will be rejected. You should follow this instruction. Manuscript submission, for a variety of reasons, not all submitted manuscripts are accepted for publications. Generally, the better the journal, the lower the rate of acceptance. An obesity journal, for instance, only 49% of submitted manuscript being accepted. Therefore, it's important to carefully and fully follow the instructions for authors. What the journal looking for, what they want. They want a fresh, new, unique material that of interest of the readership of the journal. They want studies that are important and should add to the published literature. They want articles that are relevant to the field. And the manuscript is organized and well written with good English grammar. This is also very important. The importance of strong abstract. Abstract has to be very strong because a well-written, organized abstract may be the difference between an immediate rejection or acceptance. And is the abstract written in proper English? It's very important to sometimes let somebody review with you the language and the grammar. Does the abstract appear sound? Is the topic appropriate for the journal and its readership? Does the data support the conclusion or not? The structure abstract, like a newspaper headline, it has to be very attractive and clear and limited number of words, less than 25. Shouldn't be more than 25 words and must be laser focused to the main point or finding. And the sections usually background, methods, results, and conclusions. The introduction, good introduction has to be brief, explain why did this study, and explain the study hypothesis, include the result of previous similar result, and should not be lengthy review of the medical literature. So here I come to the end of this discussion and to unethical behavior in publication. We said if you have been found guilty of an ethical violation, this can have serious consequences. Loss of the privilege to publish in the journal in the future, loss of probably department or hospital membership, a reputation can be permanently damaged. And remember that words gets around. So people, they know each other. Here, the final slide, unfortunately, you don't see it, but to give you usually the fate of your manuscript when you send it to the journal, usually first being seen by the editor-in-chief, either the editor-in-chief or the sometimes the associate editor. So the editor-in-chief will read, usually they start by reading the abstract. Sometimes they accept for publication immediately. The editor-in-chief, he said, wow, this paper is amazing. This paper likely will be accepted, and he will, and this is very rare that usually accept from just the abstract. Most of the time, if they are happy, like it, they send it for the reviewers to write their opinion about it and send it back to the editor-in-chief, and he will let you know about the acceptance of the paper. Or they will reject it immediately. And if they decide to reject it for big reason, they will not send it to anybody to review it. Commonly, you have either accepted with, but must be there some revision, or rejected with some revision. This means that they send it back, they tell you that we accepted the paper, but we have the following observation that you need to review them. Or this paper rejected, but can be improved. There is still time or space for improvement. We have the following remarks written on the paper. This is what I have tried. This is not my presentation. This is just a highlight from 8 hours, a very nice course that we attended there. And I'm apologizing again for not showing you my presentation. Thank you very much.
Thank you very much, Dr. Sultan, for your nice presentation, and we apologize we couldn't help you with your presentation. Has the panelists got any comment before we move to the attendees? Until we got a comment, Dr. Sultan, I do agree with you. Before you write a paper, you have to ask yourself, what is the aim of this paper? And one of the things you have to do for the aim, you have to look into this subject. Has it been studied? And what are the available literatures in this subject you are planning to target? And then you structure your study well, present it well, and then choose the right publisher. I agree with you. It is the ultimate, and I agree with you. We have a lot of material to present, but sometimes the lack of skill and not being aware of what's happening in the surrounding could lead to less publication. Of course, along with other barriers we have, especially in our community.
Yes, I agree with you, Abdullah. And I learned from this workshop that it's not really hard or at least painful like what we thought before. All what you need just to be well organized. Organization is very important. And step by step, you write the step where to start and where you need help. And the role of the statistician is very important, that you have to involve them in the beginning. And this is one of the issue there. The other issue is funding, because if you want to do a good study, you need support. You need support of the hospital or society to fund the research. If you want to do good research, recruit many people to work with you and professional people. The problem is when you give assignment to junior people or students, and they just want to finish the work. Sometimes they don't do it right. Sometimes they they commit some ethical issues with or without knowing. This is one of the main obstacles that we are facing.
Thank you very much. And before I give the mic to our chairman, Dr. Haider Shurafa, I'd like to thank you all for giving us part of your precious time to share together this great evening. And you were really the stars that enlighten our evening. I cannot thank you anymore, and words cannot express our sincere gratitude and thanks to all of you. I'd like to thank Dr. Talal for being with us. Sorry, we couldn't give enough time to satisfy all of you. And we know you have a lot to give, but hoping to see you in other meetings. Thank you all very much, and I'll give the mic to our chairman. Dr. Haider, please.
شكرا جزيلا لك دكتور عبد الله, Dr. Talal. Thanks for all our speaker, moderators, attendees. Of course, special thanks to our chairman, Professor Aid Qahtani, and SASMBS office, Dr. Mahmoud, Ms. Sarah. And we hope to see you again soon physically, Akid, in our 6th annual SASMBS Congress in February 2023. And have a nice night for everybody. Thank you and enjoy your time.
السلام عليكم. شكرا جزيلا. السلام عليكم.
عليكم السلام.
Bye bye. استودعكم الله.
مع السلامة.